Hello. Once again, I want to thank you all so much for joining us. We are truly honored to have you all here. I am Daniela Greenberg, an undergraduate student at Stanford, and also a proud member of the Brazil at Silicon Valley team. I'm here today to introduce to you the panel, The Future of Healthcare. While few doubt the importance of a shift to a patient-centric and tailored healthcare system, the path to its implementation is less clear. The aim of this panel is to provide insights into the components of precision medicine and the emerging relevance of preventive care. Also, we will be discussing the need to expand healthcare discoveries and knowledge to a global scale to impact millions of lives. For this discussion, we will have Dr. Lloyd Miner, Dr. David Magnus, and will be moderated by Dr. Robson Capasso. Lloyd Miner is the Carl and Elizabeth Naun Dean of the Stanford School of Medicine. With his leadership, Stanford Medicine has established a strategic vision to lead the biomedical revolution in precision health, a fundamental shift to a more proactive and personalized healthcare that empowers people to live healthy lives. David Magnus is the Thomas A. Raffin Professor of Medicine and Biomedical Ethics, Professor of Pediatrics and Medicine at Stanford University, where he is also the director of the Stanford Center of Biomedical Ethics and the co-chair of the Ethics Committee in the Stanford Hospital. Dr. Robson Capasso is the Chief of Sleep Surgery and Associate Professor of Otolaryngology and Head and Neck Surgery at Stanford University. He is also a faculty fellow of the Bayer Center for Biodesign and a global advisor for LATAM. Please join me in welcoming Dr. Lloyd Miner, Dr. David Magnus, and Dr. Robson Capasso.
So it is my pleasure to be here with Lloyd and David. It is horrible to be the moderator of a session with your boss, so that's going to be hard. I was reading about that and didn't find any useful advice for that. We hope that this audience, Lloyd and David, get a little bit more of a perspective on what both of you have been working really hard on to what you see is the future of healthcare. There's no doubt that at Stanford we are at the forefront of what's new in medicine, being on the technology side, but how to deliver it side as well that is as challenging. And we want to share this experience with this Brazilian crowd, so hopefully they can take some of those lessons home and maybe implement there as well. So Lloyd, do you want to start, please?
Sure. Well, thank you very much. I'm really pleased and honored to be here this afternoon. In particular, pleased and honored to follow two people that I have tremendous admiration and respect for, Brooke Byers and Paul Yock, two true pioneers in biotech, medtech innovation, and I really enjoyed hearing their remarks, and hopefully in our remarks and panel we can expound a little bit upon some of the topics that they covered. The title of my talk is The Future of Healthcare, High Tech and High Touch, in 10 minutes or less. But I wanted to touch on some of the things that we find exciting at Stanford and in Stanford Medicine, and how those relate to challenges that we face globally in health and healthcare delivery. Now, I suspect that all of you have heard of precision medicine. Precision medicine has revolutionized the treatment of cancer and other severe acute diseases. You know, today, a woman with breast cancer doesn't get a one-size-fits-all treatment. She receives a treatment based upon the molecular genetic characteristics of the tumor and also certain factors related to her overall health status. And the outcomes, the treatment outcomes of breast cancer have been improved enormously because therapies are tailored to the disease in the individual, the specific characteristics of the tumor, of the cancer in the specific individual. And to achieve precision medicine, we've leveraged knowledge in genomics and data science and applied it to select and, with the patient, choose the most personalized treatments that are known to have the best outcomes. Now, those same enablers of genomics and data science, those same enablers can be applied before a disease develops. And the goal of precision health, in contrast to precision medicine, the goal of precision health is to keep us healthy, to predict, prevent, and cure disease precisely. If precision medicine is about sick care, which we for sure want if we develop a cancer or severe heart disease, precision health is about health care. That is about keeping us healthy and, of course, treating us when we get sick. And I wanted to say a few words about each of those categories of predict, prevent, and cure. There is a revolution going on today in diagnostics. It's a quiet revolution, but the science of diagnostics is really exciting and progressing at a really rapid pace. You know, today, just 10 years after the initial work was done right here at Stanford, the incidence, the use of amniocentesis to determine the DNA and to evaluate the DNA of a fetus, the instance of amniocentesis used for that purpose has decreased remarkably. Decreased by 90% here at Stanford and at other centers around the US and around the world, all because of a simple blood test that can do DNA analysis of the fetus from a simple blood test in the mom as accurately as an invasive procedure, namely amniocentesis. And we see this approach to blood-based so-called wet biopsies and diagnostic procedures increasing dramatically. There are companies around us in Silicon Valley, companies like Grail. There are scientists working day and night at Stanford on advanced diagnostics. And that's going to enable us, put us in a better position to predict our propensity for disease or to diagnose disease much more accurately. Now, and earlier. Now, predicting disease is important, but it really becomes important when we use that knowledge to prevent disease. There, too, we're making progress, but a lot more remains to be done. We know that in prevention, if we're really going to have an impact in prevention, particularly in the United States, we have to, in the future, do a better job of addressing the social, environmental, and behavioral determinants of health. If we think of the healthcare pie, it's only about 30% or so represented by medical care and our genomic makeup. The other 70% or so is represented by social, behavioral, and environmental determinants of health. And it's a sad fact in the United States today that the most accurate predictor of lifespan, the most accurate predictor is the zip code in which a person is living, not their genetic code. And addressing these social, behavioral, and environmental determinants and using, where we can, technology to help to do that, and I'll talk a little bit about that in a moment, is going to be really important if we're really to improve the quality of life and life expectancy in our country and in the world. And then finally, the third component, cure, there's where we're seeing a revolution, for example, in particular in cancer, with immunotherapies, with CAR T cells. The cancer landscape has changed more in the past 5 years than it has in the past 30 years in terms of treatment modalities and their efficacy. And I think we're just at the early stages of that revolution. Let's see if we could advance. Thank you. We're sitting here today in the heart of Silicon Valley, and there's a lot of interest and entrepreneurial activity in the area broadly known as digital health. Digital health being manifested by consumer-facing devices and technologies that give us more information about our health, and also by AI machine learning analytics related to health. And I want to describe one example today, and that is a study that we just reported on about 3 weeks ago at the American Heart Association meeting, the Apple Heart Study. In just over 8 months, we enrolled about 419,000 people in an entirely virtual clinical trial. People with the Apple Watch who gave their informed consent participated in this trial, and the goal of the trial was to determine if the Apple Watch could be used to diagnose, or at least to predict, who has atrial fibrillation. Atrial fibrillation is the most common heart arrhythmia. We don't even exactly know the incidence of it in a country like the US because it can be intermittent. And oftentimes the way we diagnose atrial fibrillation is when it causes a complication like a stroke. Now, there's a lot more work to be done in this study, but there's several critically important findings that we find very encouraging. One is, when we started this study, there was a concern that, well, everyone's going to get alerts. There are going to be a lot of false positives, and that's going to drive a lot of unnecessary health care. Well, that wasn't the case. About 0.5% of the participants in the study received an alert. And 84% of the time, when they received an alert and they were also wearing a patch EKG monitor, that alert actually was representative of atrial fibrillation. We're encouraged by this, and we see this as the beginning of what can be a true transformation in the ability of us to garner more information about our health from digital devices and technologies. Oops, sorry. Now, a topic I've been particularly interested in as a physician and as a user of electronic health records has been, how can we improve the information we get from the electronic health record? How can we use electronic health records to help us deliver better patient care? It's been only a little over a decade ago that less than 10% of the medical records in the United States were in electronic format. They were in paper charts that sat tucked away in offices. Now, we've changed that in just over a decade, where 90% of medical records in the U.S. are in electronic format. But unfortunately, what we've done is we've substituted filing cabinets for paper records with electronic filing cabinets. And by and large, we're not mining and leveraging the data that currently is trapped in electronic health records to really drive improvements in healthcare delivery. That's a great opportunity for us moving forward, as well as to make the electronic health record more seamless in the care delivery experience. We hosted a conference last June, a national conference on the electronic health record. And in advance of that conference, we collaborated with the Harris poll to poll primary care physicians, over 500 primary care physicians in the United States. The majority of the time spent with a primary care physician delivering care to a patient, the majority of the time is spent with that physician interacting with the electronic health record, not interacting with the patient. We can do better than that, and we have to do better than that moving forward. I'm pleased that after that conference, one of the participants in the conference was Cliff Leaf, the editor of Fortune, and in this month's Fortune magazine, the feature long-form article in the magazine is on the electronic health record and the reporting that Fortune and the Kaiser Family Foundation, a healthcare think tank here in Northern California, did a 6-month study, intense study of electronic health records and the problems and some of the potential solutions. And we're having a follow-on conference this October to dig more deeply into these issues. I also wanted to touch on some of the things that we're doing, let's see if we could advance, please, to improve medical care globally. After this conference this afternoon, I'll be headed up to San Francisco, where the Asia Society will be giving an award to this person, Dr. Sam So. Sam is a liver surgeon, and he spent the first part of his career doing liver transplants and treating chronic liver disease. And the most common cause of the chronic liver disease in the patients that he was treating at the time he was an active surgeon was end-stage liver disease due to viral hepatitis. That's such a tragedy because we have a prevention, we have a vaccine for viral hepatitis, hepatitis B. Sam, a little over a decade ago, decided to devote himself and the resources that he was able to put together to improve the access to that vaccine in China and in other parts of the developing world. And Stanford's Asia Liver Center now has outposts in all regions of China, collaborating with the government to make sure that people get the vaccine that's available. This goes to this topic that I mentioned before about prevention and about, in order to really move prevention forward, we have to be able to address the social, behavioral, and environmental determinants of health. And one component of addressing those determinants is to get the treatments and preventative strategies we know to be effective, to get those to the patients, to the people who need and will benefit from receiving them. In closing, we want to move from patients to populations. Precision Health has the vision of leveraging the knowledge that exists today, the knowledge that we will get moving forward, in order to better predict, prevent, and cure disease. But we also need to take that knowledge from individuals and use it in populations. And there's a close relationship between the approaches that we're using in precision health and what we classically think of as population health sciences or public health. And in order to get from individuals to populations, we have to have collaborations and interactions. And that's one thing that encourages me so much about this conference today, about your interest in health and healthcare delivery in Brazil, and about the opportunity that we have moving forward to combine our resources, share our knowledge, and in so doing to have a positive impact on the health and well-being of even larger numbers of people moving forward. It's a goal that Brooke and his colleagues on the panel, Paul Yock, touched on in terms of biodesign and med tech. When we're able to innovate, when we're able to develop devices and technologies, when we're able to disseminate knowledge, we can have impact far beyond our home here at Stanford and here in Silicon Valley. And that's exactly the reason why Stanford as an institution exists and why we're so excited and enthusiastic that you're sharing time with us this afternoon. Thank you.
Now, David, thank you. Lloyd, that was brilliant, but I'm used to that already. So now, David, your turn.
Okay, thank you very much. It's a great pleasure to be here. I think it's very exciting to see so much interest and excitement about the future of health and the future of these technologies. A lot of what I'm going to say really just builds on some of what Dr. Miner was just talking about, but I'm going to take a little bit more of a critical stance about some of the concerns that I've got about what we need to address for us to realize the ultimate vision and the benefits of some of these changes in technology. Okay, whoops, wrong way. Okay. The first slide was just something, sort of a mess to show the incredible interconnection between a lot of these different buzzwords that get thrown around precision medicine, big data, learning health systems, AI, machine learning, and there's an interconnection between all those two. And I'm going to really talk a little bit, just building on what Dr. Miner talked about, that's going to drill down on the use of machine learning to really achieve the goals of precision medicine. So why do we need precision medicine? It's partly because of just recognizing the limitations of current physician practice. Physicians have a limited number of variables that they can take into account. Even when they use algorithms in their work, it's usually a very small number of algorithms, a SOFA score, an Apache score, SciPat for organ transplant evaluation. It's a limited number of data that can really easily be managed by physicians. Moreover, the data is usually based on sporadic encounters with individuals who come in and interact with the healthcare system, so it's just a series of snapshots. And then finally, there's bias in physicians' practices, right? So physicians often are heavily influenced by whatever just happened with the last patient, rather than having a view that sort of looks at a whole lot of different data and the full range of what they might take into account. So what's the solution? Large amounts of data, omics data, electronic health record data, wearable data, mobile application data, have huge amounts of data. But with that much data, that is far too complex and far too much data for any human to ever be able to understand or analyze. And so ultimately, we're going to have new computational tools and things from machine learning, whether it's deep learning or even just machine learning that's not very deep, but is just using regression with large numbers of variables. Those are all going to be different tools that are going to have to be part of being able to make use of all of these things. Just to give an example, and right now we've got a whole bunch of different research at Stanford going on that's very similar to this. When a patient presents for palliative radiation, it would be great to know whether this is a patient who's got less than 3 months to live, 3 to 6 months, or who with aggressive treatment could live for a couple of years. And you'd want to know that so you could know exactly how to titrate the treatment and whether to give them aggressive doses of radiation or send them off to hospice care. And we've got a whole lot of teams working on a whole range of different predictions using different approaches. But it would be really great to be able to do that. And similar kind of priorities about who should get organs, who's a better candidate, which patients should be sent to the ICU. These are all different things that research is going on right now to be able to do better prediction using machine learning techniques from different sources of data. So some colleagues and I think some of you may have heard Nigam Shah give a talk yesterday here at this meeting. So Nigam and I and a junior bioethicist colleagues at Stanford, who's a physician, did a paper in New England Journal last year talking about some of the challenges that arise in implementing this. And I'm just going to outline some of those problems. There's really 4 of them. One is the challenge of really recognizing the values and interests that can be embedded in the actual algorithm development process. And one of my colleagues at Stanford just got an R01 to really delve much more deeply into the way values get embedded in the algorithm process itself. Second, biases and limitations in the data that the machines learn on, because the machine algorithm is only as good as the data it learns from. Then misuse or misapplication or misinterpretation of what these algorithms show. And finally, I want to say a little bit about the ethos of medicine and how these technologies are really changing that in important ways, or forcing us to recognize some of the ways in which it already has changed. Let's see. Okay. I'll just say I'm not going to talk about privacy and security. That gets already plenty of discussion elsewhere. So first of all, values and algorithms. A lot of decisions have to be made that are value-based about what variables you're going to be looking at. And the reality that a lot of different things are going to be used in health systems may involve third-party vendors who are selling algorithms to health systems, may wind up leading to disconnects between the values and interests of the people who are developing them from the downstream users, i.e. the physicians who use them, or even the patients. So if I'm thinking about an algorithm that predicts who's going to do well in the ICU and which patients should go to the ICU or not, in the ideal world as a health system, if what you're thinking about is the bottom line, you might want to know about the ability to pay and insurance as a factor in deciding what or at least as a variable that might be taken into account in who goes to the ICU or not. That might not be something that the physicians are happy about or even know about, might not be something that patients would be happy about or know about, but you could imagine that a health system might be very interested in that. Similarly, there are a lot of quality metrics which we spend a lot of time we pay a lot of attention to because there are ways in which we're compared to other institutions and they matter for our reimbursement rates. But some of those quality metrics may not actually correspond to real care or concerns of patients and physicians. And so becoming tyrannized for some of those quality metrics, if that gets embedded in the algorithms, there are certain values that get embedded. And I'll talk in a little bit about another value that's an even tougher decision. Let's see. Oops. Sorry. Go back. So now let's talk about some of the bias limitations of the data. The first issue is the fact that there's some missing data. There's things that we just don't have enough of for different populations. And this is just one example of that. Let's see. Okay. This is studies of GWAS in the US, and I don't expect you to be able to read this in detail, but the point was in 2009, 96% of all the genome-wide association studies in the world were from people of European descent. That number got a little bit better at the time that some colleagues here at Stanford did a study to look at that, but it's still very, very small and very underrepresented. So even though, for example, Hispanic or Latino populations make up over I think it's 17% of the population in the U.S. At the time that study was done, they represented less than 0.5% of all genome-wide association studies. So if they're simply not in the data, they can't be represented there. And then second, the data can lead to actually self-fulfilling prophecies in the way in which biases in practice wind up being learned on by machine learning. So just to give you an example, in a study that some colleagues and I did, we published back in 2009, and we've got a whole series of studies we've done since then that we're continuing to work on transplant listing decisions by transplant programs. So we surveyed transplant programs. We've been looking at a range of psychosocial factors, but I'll just point out that the percent of programs reporting how often neurodevelopmental delay is actually used in transplant listing decision, and this is the data that gets most of the attention in the press. This winds up being cited a lot. But we found that, as you can see from this data, 44% of programs always or usually take developmental delay into account in deciding whether to list somebody, while 39% rarely or never take it into account. So huge variation in practice across programs about whether this is a factor. And similarly, we found differences across programs around whether or not, around whether or not neurodevelopmental delay by itself should even count as a contraindication. So you can see here that 40% would never use it as a contraindication to transplant, but 44% actually would use it as a contraindication for transplant, depending on where you draw the line. So a lot of variation in practice. And what that means is if machine learning is learning on an institution that does not list kids for transplantation, if they're developmentally delayed, it will see that there's terrible outcomes. Those kids all die, and it will reify and reinforce those existing biases. And I think that's a real worry and a real problem. We found similar outcomes with immigration status, a whole range of different social factors in listing decisions. And those biases, machines will learn from the biases because if you don't treat, it's always 100% fatal. And then lastly, the issue of even accurate, unbiased data creates a huge dilemma. Dr. Miner talked a little bit earlier about the fact that zip code right now is the best predictor of lifespan and life expectancy. So the health wealth gradient, racial and ethnic disparities that are associated with excess death, all of those things are actually quite real, and any machine learning that's going to learn on data that encapsulates that reality of the fact that people typically are more likely to die earlier and have worse outcomes as a result of inequalities in our society, the machine learning is going to learn about those things, and that creates a dilemma. The example I gave before about predicting outcomes and wanting to know who belongs in what bins. Well, given this data, we can expect that people who are from different underrepresented minority groups or people who are poor are much more likely to be in that bin of less than 3 months to live, and people who are more affluent and Caucasian are much more likely to be in the group that's going to live for 2 years. So what are we going to do about that? Because if we decide we don't want to take that into account in the algorithms, we can do that, and it will make the algorithms less predictive in terms of its accuracy with regarding outcomes. On the other hand, if we just focus on the outcomes themselves, those social inequalities that cause those problems will be reinforced and reified. So that creates a real challenge and really emphasizes why there are really difficult value choices that have to be made about the algorithm design itself, about what we're going to do about these very real problems. I'm almost out of time, but I'll just say another concern is about what I'm calling misuse of algorithms, maybe not the quite way of putting it, but healthcare systems and clinicians may not even be aware of data limitations or value bias or biases in the algorithms or the data that it's learning from. They may not be aware about all those different aspects of it. And algorithm results may be applied to individuals and populations where it's really just not as predictive. So these are all very significant problems that I think we're all concerned about. The more opaque the algorithm is, the more opaque the process is, the more likely it is that it's going to be a real challenge. And given how little most physicians know about this kind of area, the more challenging this is, I think, going to be for health systems and physicians in the future. And then I want to say one thing about the broader implications for the ethos of medicine. A lot of our ethics, when we teach ethics and think about ethics, we really pretend that most of medicine is about an interaction between a patient and a physician. Most of our ethics, going back to Ed Pellegrino and earlier, and actually going all the way back to Hippocrates, it's really on the assumption of a dyadic relation between a patient and a physician. Well, that really hasn't been true for a long time. There's a lot of ways in which the relation is really with a health system and a healthcare team. And now it's going to be with a healthcare physician and an algorithm who may be driving decisions or helping to drive those decisions. We know for some data that other folks have collected at Duke and Hopkins that patients want to know when their physician's autonomy is limited, whether that's by pathways or by algorithms or by anything else. Even when it produces better outcomes, they want to know about it. So one of the big questions, I think, is how do we reframe our notions of relationship and obligation in a setting where it's that the myth of the relation between a patient and physician is not really the accurately capturing the relationship, which is really between a community of patients and providers and analytic tools, and that we want to learn as we go. And I think we're just at the very beginning phase of trying to think about what that would look like. Some colleagues at the Hopkins and working through the Hastings Center and the Institute of Medicine, now National Academy of Medicine, have done some of these things, and really to think about what it really would mean for patients to be part of a robust learning health system where every patient is also a research participant and also a partner and also feeling empowered in different ways in which the process. And what would it look like to really change at a fundamental nature the nature of what it means to be a patient and what it means to be a physician in this community of learners where we work together to take advantage of all these transformations to really produce a better healthcare for tomorrow. Thank you very much.
Well, that was brilliant. David, so on that line, so we are now having then some people talking about augmented reality where perhaps the availability of data will give it back. The humane aspect of medicine where you're actually going to have more time to have contact with the patient. But at the same time, there are concerns or how do we train the doctor? I mean, this is a completely different way into what we do medicine. This is not something that the doctor is traditionally trained to work with this level of technology. At Stanford, we are privileged to have, but what is your view on the new training of doctors for dealing with this new reality?
Yeah, I'm sorry. Is that okay? So yeah, I think there's actually at least 3 different things that need to be done. So first is, Dr. Meyer talked about high touch. I think that's important. We know empirically that the uses of electronic health records, uses of some of these things can lead to less interaction in the way in which physicians can interact. We also know, and there's some interesting studies that have been done showing ways in which can lead to positive interaction. So for example, having patients look at a screen with the physician as they sort of see and learn from things. So that's the first thing that has to change, is to train physicians to be able to use this technology in ways that don't isolate them from their patients. Second thing that needs to be changed is that physicians are going to have to know a lot more about things that they don't know about now. They need to know a lot more about genomics, and they need to know and its limitations. And I didn't go into this here, but we've got some very scary data that we've started to publish about interviews with clinicians who are making decisions based on clinical genomic findings that they really shouldn't be making those decisions based on those. And so they need to know more about genomics, and they're going to need to know more about algorithms. They're going to need to know about medical informatics. That's going to have to become part of the training of future physicians, and there's just no way around it, and that's a real challenge. And then third, I think we need to rethink about how we think about relationships and the physician's role in creating those kinds of relationships. And one thing that always frustrates me, and is something that we spend a lot of time dealing when we have questions or issues, like the issue about value when we're doing algorithm design. Do we want to reify that injustice? Or are we willing to be less accurate? Where should we side on that? There's a tendency when we have to make difficult decisions to just focus on the physicians who are making these decisions without bringing in that patient voice. So I think we need a lot more deliberative engagement at a systematic level in the way we tend to think about things, and really to think of patients as partners.
Lloyd, I don't know if you want to... So we see a lot of patients these days, and we have a somewhat... I would say, concentrated population here in Silicon Valley that has the use of wearables, smart everything, all sorts of bracelets, smart beds, smart cars that give us an array of data. And the doctor sometimes gets 500 pages of report or Fitbit data to check on the clinic. So there are some challenges perhaps to incorporate Apple Watch data. How do you foresee that digitally driven practice moving forward at Stanford?
I think we're at the very, very early stages. You're exactly right. Most of these devices and technologies are not compatible or only compatible with a lot of effort to standard electronic health record systems, and they're usually oftentimes not compatible with each other. And there is a lot of work to be done. Where I think it's first going to be applicable, and where we focused in some of our primary care practices, is we know that there, in the Medicare, the government insurance program, 70% roughly of the Medicare costs are to provide care to less than 20% of recipients. These are people who have multiple chronic diseases. And the key to keeping them healthy is to monitor and track their care at home and make interventions early at home so that a patient, for example, with congestive heart failure, if their weight starts to rise a little bit, if there are other indicators, there can be interventions at home and they don't wind up in the emergency department and then being admitted to the hospital again. And I think building a connected home, in first focusing on the patients who are at greatest risk of needing hospitalization and incorporating that into the way we deliver care and the way we record medical information, I think that will be the most useful place to start, but even that is a big lift right now.
Exactly. So I need to ask those questions for both of you. So Brazil, in a sense, has some of the similar challenges as the United States. We have a huge concentration of great doctors in São Paulo or Rio or in Boston or in New York. Perhaps some of the less populated areas are less served on doctors. So if both of you were given carte blanche to design a new healthcare system, completely from scratch, learn from the lessons, from the good things we have, from the not so good things we do in the United States, and someone tell, listen, develop a healthcare system from a country that is big, have some concentrated population in some centers, less concentrated in some others. How would you do it? That is an easy question.
Okay. Well, I think the key first is aligning payment, whatever system of payment one chooses, aligning payment with outcomes, so value-based reimbursements. And there are lots of ways to do that. One is by bundling services. So now in a number of different insurers in the US, for some of the more commonly performed procedures like hip replacements, knee replacements, certain forms of cardiac surgery, there's a bundled payment made to the delivery system, the physician groups, and it's intended to cover everything, the hospitalization, if it's a surgical procedure, the anesthesiologist, the surgeon, and a certain period of time after the surgery is performed. If the patient's in the hospital for one day, that's the same payment to the hospital. If the patient's in the hospital a week, it's the same payment. So the incentives are to make sure that the care is being delivered efficiently and effectively. And to start that transformation, I think it means us all being much more transparent about how we report our outcomes, agreeing upon certain standardized metrics, and then also giving us feedback as physicians on the cost of the care that we're delivering. Several systems have been pioneers in this. Intermountain Healthcare in Utah is one that comes to mind. You know, just the simple act of, for the urologists that are doing prostate surgery, making them all aware of how their costs per procedure compare to their peers was enough of an intervention to drive a change in practice for many of those outlier practices for which costs were greater than the mean or greater than the other people in the group. Now, we have to be careful about doing that and make sure that people still get the care they need to receive. But right now, in a strictly fee-for-service system, which by and large U.S. healthcare delivery system is fee-for-service, there's not a direct alignment between outcomes and reimbursement. In fact, strictly speaking, a fee-for-service system rewards more increments of care, more procedures, more tests. It doesn't necessarily reward achieving better outcomes. I think moving towards bundled payments, risk sharing on the part of providers and healthcare delivery systems, all of these are going to be important in achieving greater value for the U.S. healthcare delivery system, and they are principles that can be followed in other countries. You know, there are many examples of highly performing systems. There's no perfect system, but one that I would cite is the healthcare delivery system in Israel, which there are 4 large HMOs in Israel. They are private in that they're funded, you know, they're operating as companies, they have investors, and the hospitals and physicians are by and large employed by the government, by hospitals or by delivery systems. And so it's a mixture of, it's not a single payer system in that there are multiple HMOs, but there is enough competition and enough focus on outcomes that I think Israel spends about 7% of GDP on healthcare, and by a number of different metrics, their health outcomes are really quite impressive. There are lots of different ways it can be accomplished, but I think the fundamental principle is aligning reimbursement to outcomes and to value.
Dave, I don't know if you have any comments on that.
Yeah, so I agree with most of what you said. I think the problem with fee-for-service and the disaster that it's been in a lot of ways for our healthcare system is obviously a starting point. And I also agree that if you look at different healthcare systems around the world, they all have different trade-offs and different challenges, but they all have certain things in common compared to the U.S., namely much lower cost and on the whole better outcomes. So it's not that hard to look at options that are better than ours, and there are a lot of different ways of delivering that and setting that up that would achieve that. But I also am skeptical of the idea of saying designing something from scratch, because I mean it's not a coincidence that we have fee-for-service and kind of the problems we have. Every system is a function partly of its history, and you know it's decisions that were made in the 1930s that were politically made are partly why we have the system that we have. So I don't know that you can really truly design something from scratch. But if you could, and I was in a fantasy world where I could really truly start something from scratch, then in addition to all the things about trying to get the proper alignment between the right, you know, incentivizing physicians in the right way to do the right thing and to have your reimbursement matched to the incentives that we care about, I would actually also set things up so that you have different cultural expectations of the public, and it's made part of the way in which people are learning. So the learning health system that I was talking about before, I think every patient who's in one of these HMOs, if you have a limited number, I think everybody should go into those systems and be taught right from the beginning that, you know, if we know what the best thing to do for you is, we promise we will do that. And we will try our best to keep that promise. And if we don't know what the best thing to do is, our system will be set up so that our electronic health system will randomize you so we can answer that question. And so people should go in. If we know it's Phil Lavoie, a colleague who just recently retired from Stanford, said, if we know it's best, do it. If you don't, randomize. And I think creating that expectation that that's what everybody would get automatically, that would be my fantasy world of something that we would do.
Excellent. Well, I feel that we just scratched the surface of what is possible, picking up in the brain of those two. I really appreciate both of you coming over here. I hope this is just a start of a relationship between all of you. And it's our responsibility as well, how can we make this closer connection with Stanford and Stanford Medicine. Thank you all for coming over here. Thank you.
Thank you.